Welcome to this whistle-stop tour of our BAUS FRCS Urol VIVA preparation course. This is one of a number of educational courses run by BAUS.
We have about 70 faculty who come and help throughout the week, from doing their presentations to helping out with the mock examinations in the afternoon.
It's a fantastic opportunity, working with your knowledge, building the skills you have, building the knowledge you have, and getting into a point where you can deliver it at an expert level in an exam setting.
You get to meet people from other regions, a bit of networking, just generally making you feel comfortable by the time you finish the course that yes, you're ready to do the exams.
The experts have given us great lectures all week, knowing those key up-to-date research and guidelines, and getting us to the point of being consultant urologists.
The structure of the course actually is absolutely brilliant because it allows you to learn in the morning, and then you get grilled in the afternoon.
Very focused lectures in the morning and excellent viva practice in the afternoon. It's fun, you get along with people, you get to practice lots.
It's a great opportunity to see all the stuff here and all my colleagues did a good job. And we learned a lot.
The vivas were handled expertly, and it was probably the most useful thing I could have done, really. Really, really good from the faculty.
So during the week we've had excellent viva support, sort of coaching, how do you get that extra mark?
I've learned quite a lot from other people, so I think that's been invaluable.
I wasn't lucky enough to get on the course for myself when I was a registrar, which I think is a real shame because towards the end of the week they really do become quite slick at answering viva questions.
This is a fun, interactive week to help trainees organise and present the information.
You need a course like this to stimulate and remind yourself of the information that's already in there.
It's quite obvious that the people who start off on a Monday are completely different than how they are on the Friday.
It's bloody hard work, but in the end it's one of the best courses I've ever been on. Very much worth it for everyone to do.
It's a busy, exhausting week. It's absolutely worthwhile.
Highly recommend it. I think it really is essential for anyone trying to do the FRCS.
I would definitely recommend it to anyone.
Excellent course. I definitely recommend it.
It's been a real pleasure to help some of these candidates along the way.
Good afternoon. It's with great pleasure that I introduce the BURST Research Collaborative session of BAUS 2020. My name is VEERU Viswanathan, and I'm chair of the BURST Research Collaborative. So this year's session is slightly different to normal. We're going to have a combination of teaching on the evidence base behind common urological practice, as well as linking that in with some of the projects that BURST are doing. And I want to give people an overview of the kinds of activities we're doing so that they know how to get involved. And I want you to get involved from what we talk about today. So we know that research on your own is challenging, but we don't want you to be on your own. There's a solution to performing good research in a coordinated way. The solution is the BURST Research Collaborative. So we were founded in 2015, and we're an international network of urologists, radiologists, residents, methodologists, allied health professionals who work together in order to produce high quality collaborative research and audit and education to do so. Now, we've really moved beyond a trainee-led organization to being one which is producing work which can influence practice in a number of ways. And the founding principle has always been the same, that a small amount of work by each member of the collaborative can collectively lead to a large, well-powered study and go towards something that's meaningful, that can improve patient care. So there are a number of benefits of being involved in collaborative research. Many benefits are for the individual, who will gain skills by being part of that network and developing team leading and team working skills, specific skills on data analysis, the ability to write papers. There'll be benefit to the units who are associated with this higher quality work. And most importantly, there are benefits to the patients. That too, collaborative research is rewarded by the UK training body as achievements towards completion of training. With patients at our focus, we're very proud to have involved Rachel Jury and Jacqueline Emks as part of our working group. So they're an integral part of our committee, and all of the work we do is run by them so that we can make sure the work we do is patient focused. In addition, we have a growing committee of 22 members who manage all of the work that you see. I'd like to thank each and every one of them for their hard work behind the scenes. Particularly, I'd like to thank Tamer Shah, who has been one of the original members of the Burst Research Collaborative, and he is currently Vice Chair. They will be stepping down from Vice Chair in January 2021. And congratulations to Sinan Kaduri and Nikita Bhatt, who will be Joint Vice Chair in January. And really, this is an opportunity to say thank you to all of the collaborators who are watching this from around the world. As part of the Burst Research Collaborative, all of you have been able to get involved, and there have been presentations around the world. Many of you have been involved in prize-winning pieces of work and had the opportunity to get involved in publications, which is why in the last 5 years, we've been able to involve more than 1,000 collaborators for pretty good outcomes. So now really I wanted to touch on some of the highlights. I wanted to highlight the diverse range of subjects and projects that we're doing within Burst, and particularly some of the things that we've achieved over the last year. So first of all, for new partnerships. We're very thankful to Freddie Hamdi for forming a collaboration with us in the BJUI. And we have a dedicated section of the journal for articles relevant to trainees, which can be written by trainees or non-trainees. And we'd invite you to have a look at the BJUI website to see the types of articles we're interested in, and drop us an email if you'd like to write something. The BJUI is an excellent journal, and it's a PubMed index journal, and it has a wide international reach. So we again thank Freddie Hamdi for his foresight into appreciating the importance of listening to the trainees. We also have a collaboration with BJUI Knowledge, and we have a set of research modules which will be freely available to people around the world that will educate people on the basics of research. And for those who want a bit more information, there are modules on how to do particular things. That goes towards our mission of educating people how to perform high quality work. So Mimic. Many of you would have been involved in Mimic. It was one of our flagship projects, and the work has been going on behind the scenes. Many of you will be familiar with the famous Darren Smith slide from Twitter, which shows how useful some of the work we do can be. And I myself use this slide in my day-to-day practice when we see patients with acute ureteric colic who have a stone, and we want to decide whether or not we can manage them conservatively, and we want to counsel the patient for subsequent management. And we use the data from Mimic to do that. And behind the scenes, we are working on an app which is ready, and we're going to hopefully publish the data soon, which will allow any patient or physician around the world to enter their data to see the chances of them passing their own stone. So everyone will be familiar with the Identify project, which is the largest prospective study of hematuria ever performed in just over 11,000 patients. We have published the protocol from this, and a couple of papers are in submission to peer-reviewed journals as we speak, and hopefully you will see some more of the data from that, which I understand is eagerly awaited. Leading on from Identify, which looked at diagnosing urothelial cancer, our next flagship project is Resect. And if there's one thing I want you to take away from this talk, it's learn about Resect and take part in the project. We have a real opportunity here to improve patient care. Patients who have TURBTs for bladder cancer are subject to a technique which we know has quite a lot of variation. Work from the Scottish Quality Improvement Project showed that if you perform the TURBT in a particular way and share the results of your performance with other centres in an anonymised way or non-anonymised way, you can actually improve the quality of your TURBT. And we're going to do this on an international scale. So we're looking at a number of factors and how they influence whether or not people can achieve those quality indicators. And we're looking at how those variables relate to early recurrence rate. And you'll hear more about that later. We've already got 615 collaborators around the world who have pre-registered for this study. So this will be the largest study of TURBT ever performed. So let's move on to stent, which is looking at stone disease. And one of the things we were interested in from our previous Dragon's Den session at BAUS a couple of years ago was looking to see whether the routine use of stents after an uncomplicated ureteroscopy was necessary. And it seemed that there was quite a lot of variation in practice. And so we wanted to understand this and see whether a randomized trial comparing the use of a stent or no stent after an uncomplicated ureteroscopy was feasible. So we're very pleased to have published the stent survey results in the BJUI Compass, which highlight the variation in practice, but particularly highlight that it is feasible for us to conduct an RCT comparing ureteric drainage or not. And you'll hear a bit more about this later. And I'd encourage you to stay involved with this, as we anticipate this will be a randomized trial carried out in centres around the UK or even beyond that in the coming years, which you can get involved in. So we move on to some of our work in testicular torsion. So one of the systematic reviews which we did is now published in European Urology Focus, looking at the technique we use for testicular fixation. And many of you will be aware that when you move from one centre to another, different surgeons have different preferences. And whether or not you fix both testes, what material you use, how you fix them, these are all questions that are open for discussion. So our systematic review highlighted that there is no strong evidence in favour of one particular technique over another in terms of improving longer-term outcomes. Therefore, we want to identify by consensus what recommended techniques could be in the absence of high-level evidence. And we have formed a collaboration with BAUS, have started the consensus meeting process, and hope to produce some emergency guidelines for the management of testicular torsion. In our theme of testicular torsion, we are also working on a study called Detox, which is looking to disrupt the way that we manage patients with testicular torsion. So we know that many patients undergo scrotal exploration. If in doubt, explore. That is the taught diktat. However, we understand that a lot of patients will undergo an unnecessary exploration, and having an operation is subject to its own risks. And in collaboration with our patient focus group, we believe there is room for improvement here. So we want to run a diagnostic test evaluation study to see whether or not ultrasound in the hands of the urologists or surgeons who would do the scrotal exploration can identify which testes will be torted. And this is a controversial study and in development, and we welcome the views of people in the audience and our collaborators in engaging in this work. This is something for the future. So no talk in 2020 will be complete without mentioning COVID. So I will mention COVID. We have formed a collaboration with the COVID Surge Collaborative, and we have data for over 2,000 patients who have had bladder cancer, prostate cancer, and renal cancer surgery during the pandemic. Our aim really is to see whether or not COVID has impacted the outcomes for these patients. And we have been permitted to have long-term follow-up for the bladder and renal patients for 3 years and prostate for 1 year. And many of your centres will be involved in this, or you may be moving to a centre which is involved in this, and you can get involved in the data collection and be recognised for that when we come to write up the papers. We really have an opportunity here to understand more about the natural history of some of these cancers. Now, we've also delved into the undergraduate curriculum, looking at developing the next generation of urologists. And one of the things in collaboration with BAUS is we're looking at how well urological teaching is taught in medical schools. So over the past year and a half, we've developed a project called Learn, which is investigating this. And we actually launched this around 2 weeks ago. And I'm pleased to say we have over 4,500 responses already. And with these results, we hope to develop the curriculum for undergraduates in urology for the future. And you'll hear more from that from one of my colleagues, Alex, later on. And just to mention and touch on a few other opportunities, the BURST BJUI podcast series is one that is going strong. These are based on NICE guidelines published by the BJUI, and people have an opportunity to record a podcast summarizing the NICE guidelines, and these are published on the BJUI website. And if you're interested in this, please have a look at our website, and you can see the way to get in touch with Eleanor Zimmerman, who's leading that. There are opportunities for peer review, and if you're interested in gaining skills in critical appraisal, just email us with your CV and we can put you in touch with the appropriate editors. So to summarize, as an overview, I hope we've given you a taste for the kinds of work we're doing in BURST. I hope it's interested you in getting involved. We've demonstrated that this work can influence patient practice and can benefit our patients. You have an opportunity to contribute on many levels. At your center, you can recruit patients for studies and be recognized for it, which can contribute to your CCT. Also, it contributes to audit requirements. You can propose ideas and you can be the lead of a project if you want. And you can join the project steering committee for individual projects or the BURST committee if you're interested. And I wanted to thank you for listening to the BURST session, and particularly thank you to all of our sponsors who I list on this page here, without whom a lot of our work wouldn't have been possible. And although we're socially distancing celebrating these days, please do join us on Instagram for our socially distanced photos and Zoom call photos where we update you on some of the funner things that we're doing in BURST as well. So thank you very much for listening, and I'll hand over to our first speaker. Thank you.
Hello, my name is Ben Ayers and I'm a consultant urologist and honorary senior lecturer at St George's University Hospitals NHS Trust. I'd like to thank the organisers for inviting me to talk today, and my talk is on how to achieve an optimal TURBT. These are my disclosures. So back in 2002, Maurizio Brausi published some data from EORTC trials, so good quality trials, but he found that the 3-month recurrence rate after TURBT varied significantly between institutions. For single tumours, the recurrence rate was anything from 3.4% to 20.6%, and for single tumours that had had a single shot of chemotherapy, it was anything from 0 to 15.4%, and for multiple tumours that then had some adjuvant chemotherapy, it was anything from 7.4 to 45.8%. So highly variable. Why should a standard urology operation done as part of a trial have such variability between hospitals? Well, he looked at this and he put together a training program, and he found that after senior staff and trainees or residents went through the training program, the 3-month recurrence rate reduced amongst senior staff from 8% to 3%, and from trainees from 28% to 16%. Year on year, apart from the final year, there was increased muscle found in the specimen, 57%, then 69%, 88%, and then 79%. And there was also a reduction in complications, particularly perforation and major bleeding. And therefore, dedicated training does appear to improve the quality of TURBT. I also think that before you do a TURBT, careful planning and assessment are essential. So you should look at all the preoperative information that's available to you, the history about previous bladder cancer and previous treatments, the imaging you have, the flexible cystoscopy findings, and the urine cytology. At TURBT, before you start, you should do an examination under anesthesia to stage the tumour, and you should do an accurate assessment of the bladder. Using a bladder map for this is crucial. You should use optical enhancement, so that's photodynamic diagnosis or narrowband imaging. You should use a flexible cystoscope as part of that assessment to really have a good look around the bladder, or if you're only using rigid scopes, then make sure you're using multiple lenses, so have access to 12, 30 and 70-degree lenses. And when you see any abnormalities in the bladder, you mark them on the bladder map and you look at the number, the size, the location, and the characteristics of any tumors or other abnormalities. So I'd strongly encourage you to use a bladder map such as this, noting the posterior, anterior, lateral, and dome of the bladder, the trigone and the ureteric orifices. But what other key indicators are important for a quality TURBT? The NICE guidelines suggest that we should use either photodynamic diagnosis, narrowband imaging, cytology, or a urinary biomarker test, along with white light guided TURBT. And this is because these have been shown to increase the detection of carcinoma in situ. Using a checklist has been shown to improve quality. And here on the left, you can see a graph showing the more checklist items ticked off on the checklist, the higher the probability of detrusor muscle in the specimen. One should consider en bloc resection. This enables you to remove the tumor, as you can see in these pictures, as one specimen. Here I'm using a loop, but you can use laser or other power modalities to do the incision. And here you can see you've got the tumor with a nice layer of muscle underneath. And this transposes into the pathology that your pathologist gets. And here you can see the tumor invading into the lamina propria, but not the muscle to the left of the picture. So you get better orientated pathology with en bloc resection. That's not possible for all tumors, and particularly large tumors, and sometimes the location stops you doing it. But always think, can I do an en bloc resection? Another quality indicator is having detrusor muscle in the specimen. And this paper here shows that if there was detrusor muscle in the specimen, recurrence rates, early recurrence rates were significantly lower. In Scotland, they've had quality indicators for TURBT for a number of years now, and they recently published their experience. The quality indicators they particularly look at in TURBT and non-muscle invasive bladder cancer is use of a bladder diagram, presence of detrusor muscle in the specimen, giving a post-op single dose of mitomycin C, and re-TURBT in high-risk cancer within 6 weeks. These graphs show the first 3 quality indicators. And what you can see in the middle table is that year on year of the green bars, the use of a bladder map increased. The amount of detrusor muscle in the specimen stayed fairly stable, and giving of mitomycin C stayed fairly stable. That's in purple. The bottom chart is based on hospital volume. And you can see there, particularly with the yellow bars from detrusor muscle, that the more cases a hospital is doing per year, the higher the chance of finding detrusor muscle in the specimen. And therefore, this is some evidence that volume of caseload may improve quality. Another quality indicator, as shown there from the Scottish data, is giving a single dose of mitomycin C, and we're going to look at some of the evidence for that now. Before we look at the evidence, I just want to go over the contraindications. Do not give it if there's a perforated bladder or suspected perforation. If it leaks out into the pelvis, it causes significant and persistent pelvic pain. Do not give it if there's heavy bleeding or if there's history of allergy to mitomycin C. This is the key paper that was published by Sylvester in 2004. And here he combined 7 randomized controlled trials for a total of 1,476 patients, and found that there was a 39% reduction in risk of recurrence if you gave a single dose of post-operative chemotherapy. They also reported that one installation was insufficient if there were multiple tumours. He then went on and did another meta-analysis, this time using individual patient data, and this was published in 2016. And here there are more patients and more studies, but again, a single dose of mitomycin C or other chemotherapy did show a reduction in recurrence rates. However, they did find it was only effective in low-risk non-muscle invasive bladder cancer and some intermediate risk tumours, i.e. those with an EORTC recurrence score of less than 5. So in summary, how do we achieve a quality TURBT? Well, we need to look at some key performance indicators such as the checklist, bladder map, detrusor muscle in the specimen, giving a single dose of mitomycin C, and what is your recurrence rate. I would argue that optical enhancement improves the quality of TURBT, and therefore either photodynamic diagnosis or narrowband imaging should be used. I've shown some evidence that shows that dedicated training programs and high volume centers achieve better outcomes, particularly with detrusor muscle and reduce complications. So in summary, do it right the first time. Do a high quality, complete, safe TURBT first time. The option of being able to do a re-TURBT in high risk disease or giving adjuvant intracycle treatments are not at all alternatives to doing it right the first time. Thank you for listening, and I'd now like to open the floor to any questions.
Good afternoon. Welcome to the official launch of the Resect study. First of all, I want to say a huge thank you to our funders, without whom this study would not be possible. In this presentation, I will firstly cover why we need to do this study, and then I will go into detail about how together we are going to do it. This operation that we all think we know becomes more complex and nuanced every single one I do. This operation is so common, it is expected that every urologist can competently perform it, yet it is neglected. It is underappreciated in its complexity and how variation in the quality has a major impact on the whole subsequent course of a patient's bladder cancer journey. The muscle resection makes my toes curl every time. So does the quality of the surgery really have an impact on outcomes? We've known since 2002 that there is something important happening in those operating theatres that the EORTC trials of intravesical chemotherapy did not capture. Browsey showed that even when you controlled for chemotherapy use and tumour factors, there was still a huge variation in the recurrence at first check cystoscopy between the centres enrolled in the 7 EORTC trials of mitomycin C, and they concluded that surgical factors must be at play. Then Mariappan proved this in 2012, and he went on to establish a national TURBT quality improvement program in Scotland, where we get a hint that in the setting of a national audit program, reporting TURBT quality indicators can improve performance over time, although we cannot conclude from these data that this impacts recurrence rates. Then just earlier this year, there was an explosion of interest in this idea that TURBT is the neglected procedure, that we need to ensure operative quality, and that we can do this at scale as shown by the now published experience from Scotland. It is clear that there's an appetite and an energy to improve the quality of TURBT, and this study is therefore timely. One thing about TURBT and non-muscle invasive bladder cancer is the sheer scale. There are 500,000 cases diagnosed every year globally, with 10,000 in the UK, 80% of which are non-muscle invasive. What I notice is that the annual incidence significantly underplays the disease burden, since for many people this becomes a chronic disease that they live with, undergoing surveillance and repeat surgeries over many years current estimates suggesting that 100,000 people in the UK are living with the disease at any given time, all of whom with the potential to recur. And of course, this comes with a huge economic cost. Bladder cancer is one of the most expensive cancers to treat. Intermediate risk disease costing about $150,000 over 5 years in the USA. Average cost over 3 years in the UK, about £9,000 per patient. But it's not just the economic burden. This study by Cox et al. Demonstrated the significant decrement to patient health-related quality of life from non-muscle invasive bladder cancer driven by recurrences and progression over a 3-year period. Therefore, even a small impact on recurrence rates, when applied at scale, will have huge benefits for healthcare costs, healthcare resource usage, particularly theatre time, and most importantly, for patients' quality of life. But we're talking about doing an audit. How can this really make a difference to patient outcomes? Let's be very clear about what we're not doing. Public publication of surgeon outcome data is fraught with concerns and controversy, not least around data quality, risk adjustment, case selection, and impact on training. This review in the International Journal of Surgery concluded that outcomes and risk adjustments needed careful study and refinement, and that's exactly what we plan to do. In 2020, there was this big editorial in the BMJ about revitalizing audit and feedback and about how the power of audit and feedback to improve patient care is currently underused. They concluded that the potential of audit and feedback to improve patient care could be realized through a more evidence-based and imaginative approach. Evidence-based, imaginative, well, Burst Urology are on it. So what the Resection study is a huge, exciting, modern propulsion of audit and feedback into the digital age with the primary objective to determine if audit and feedback can improve the quality of TURBT surgery. So for every medical student, junior doctor, trainee, consultant, healthcare professional taking part, how are we going to do this together? First of all, we need a massive study team. It's like a big tree with many branches and leaves, and we're all connected and collaborative. You can read this at your own leisure. The most important thing of all, the collaborators across the world poised to undertake this great task of innovation and improvement. As far as we know, we have registered interest from pretty much all urology units in the UK, around 140 with 290 individuals. There's a large presence in Spain, increasing presence in North and South America and in Asia. Make no mistake, this will be a truly global study. The audit will include patients undergoing curative intent surgical treatment of disease presumed preoperatively to be non-muscle invasive bladder cancer. We will accept new and recurrent tumours, but the number of recurrent is limited to 5 per 20 cases, since these will be in a separate analysis. More details and exclusion criteria can be found in the study protocol on the website. The primary outcome is the rate of achievement of key TURBT quality indicators. We are not listing these currently for good reason. The secondary outcome is the early recurrence rate. We are asking each site to submit a minimum of 25 prospective cases. At least 20 of these must be new tumor TURBTs, but you must also submit at least the same number of retrospective cases done before the study started. These numbers were chosen to allow most centres to comfortably complete recruitment and follow-up in way less than the 1-year time period that is allowed. You will first complete formal registration documents for your hospital, including a detailed survey about normal practices. This will be released soon if it hasn't been already by the time the presentation is going out. At this stage, the lead collaborator will be given their REDCap logon. In REDCap, they will complete data form about each of the surgeons performing TURBT at their hospital. The surgeons, importantly, the surgeons will not be named in the database. The database will be surgeon, hospital, and patient anonymous. They will also register details of the other collaborators at their hospitals who need REDCap logins to do the data entry. And then you will enter data about eligible TURBTs done before you registered for the study. When a minimum number of these have been submitted, you will be invited to begin submitting prospective data for TURBTs done after you began the study. The design and timing of the feedback intervention is currently being refined. You will follow your patients up for path results, for residual disease at re-TUR where applicable, and for the first follow-up check cystoscopy. 25 prospective and 25 retrospective cases is the minimum number required for a hospital to take part. And for this, you will get 3 collaborative authors, usually a supervisor and 2 collaborators, but we strongly encourage you to submit more than this, and many hospitals will be able to do that. For each additional author, you will need an additional 10 prospective and 10 retrospective cases, and therefore you can see that the number of prospective TURBTs performed is going to be your limiting factor for additional collaborators. So I would encourage you to determine how many new tumor TURBTs are performed at your hospital, probably over a 6-month period, and therefore calculate how many collaborators you can get on board to help you to complete the study. The more cases submitted, the more chance of being invited into the main author line, the manuscript writing committees, and higher chance of being offered to present the whole study data at conferences. Some important things we want to emphasize as we begin: the cases submitted must be consecutive cases from the whole list of TURBTs done at your hospital. They cannot be selected in any way. That means that all surgeons doing TURBTs at your hospital have to be included. Each collaborator will have a personal login for the REDCap online environment. All collaborators will, at some stage, be given access to a dynamic data dashboard. Here you will be able to explore your performance and your hospital's performance against any subcategory of records in the database. You will be able to filter by country, hospital type, and also select patient subgroups so that outcome measures can be displayed in a way that's meaningful to you and your team. A very important point about this is that no hospital and no surgeon will be named in the reports. You will have an anonymous code that refers to your hospital and a code for each of your surgeons. You will be able to see which data point refers to you, but nobody else will, and you won't be able to identify anybody else. We want this to be a valuable tool that you can use independent of the study to measure and improve your practice. I won't go through this slide in detail, but I wanted to just highlight and suggest how you might identify cases, particularly the retrospective cases. Consecutive eligible TURBTs from all TURBTs done at your hospital must be included. I would suggest asking your theatre data team, for instance, to produce reports for these for you. E.g., you could use a theatre management database such as ORSOS or OR Management. The OPSC4 operative codes for TURBT and biopsy and diathermy are listed here. And there's also some additional advice on this slide about how practically to undertake the study. All of this will be explained in detail in the study instruction materials that will be provided to you before you begin the study. So in conclusion, Resect aims to be the largest study of TURBT surgery ever performed and will launch the idea of audit and feedback into the digital age. Given the sheer scale of non-muscle invasive bladder cancer resource usage and patient impact, the opportunity for improvement is vast, and we hope that our collaborators will get significant personal benefit from participation and undertake the study with the same energy and enthusiasm with which we have designed it. Thank you very much for listening, and I look forward to taking some questions.
So good afternoon, everybody. My name's Tamer Shah, and I'll be giving a very brief talk on the use of imaging and nomograms in assessing acute scrotal pain. When most of us think about acute scrotal pain, the first thing probably that comes into our head is, could this be a torsion? And should I explore? The problem is that for many, actually, it probably doesn't matter, and they still follow the old adage that we should all effectively explore all acute scrotal pains. But why? Well, probably due to the fact that we don't want to miss a torsion, but also there have been many cases of litigation surrounding a missed torsion. But we're in the 21st century, and we actually have access to a lot of other means of helping us make a diagnosis and getting the diagnosis right. These include imaging such as ultrasound scans and nomograms that have been developed over the last few years. Ultrasound itself is actually not new. It's been around for a very long time, but the data has slowly been maturing over the past, really the last 5 to 10 years. The two key findings are either reduced Doppler flow, and on the image on the left, you can actually see, sorry, the image on the right on the screen, you can see that actually one of the testicles has much better Doppler flow than the other, indicating one has potential ischemia. And the other sign is called the whirlpool sign, which is actually a twisting of the cord that can be seen on an ultrasound scan as well. And what the data shows is that when you analyze all the studies together in a meta-analysis, where there's over 2,000 patients, the diagnostic accuracy of ultrasound is very high, with a sensitivity of almost 90% and a specificity of 95%. And similarly, when you use the whirlpool sign in a meta-analysis, the pool sensitivity is again well above 90%. And actually, if you combine the two ultrasound parameters, you can actually get very high levels of accuracy for diagnosing a testicular torsion. And in addition to this, there's been work done predominantly from the US in developing nomograms that might actually help us determine how likely it is a patient has a testicular torsion. One of the main ones is the TWIST score, which gives you a score from 0 to 7. And effectively, it uses parameters in addition to testicular pain to rate a patient as either low, intermediate, or high risk of having torsion. And the key finding is that as the score increases, your likelihood of having a torsion increases. But actually, when your score is 0, you've almost got a 0% chance of having a testicular torsion. And this data has been validated in various cohorts around the world now. But overall, why does this matter? And the reason it matters is that actually, on clinical examination alone, the negative exploration rate consistently throughout the literature is about 50% and can be as high as 80%. And this is a reference from the BJUI, where actually 10% had a completely normal examination after a scrotal exploration, and the other 40% had a completely different diagnosis. So we're wrong 50% of the time when we just use clinical examination alone. And negative explorations aren't risk-free either. This is straight from the BAUS consent form, where up to 10% of patients may develop a hematoma, up to 10% may need antibiotics or surgical drainage for an infection. And these aren't small risks, particularly for that group of patients who had actually nothing wrong with them on scrotal exploration. And we know that actually utilizing some of these more novel diagnostic tools such as ultrasound or the TWIST score can reduce negative exploration rate. Ultrasound in some small studies have been shown to reduce it by 10%. I suspect we could probably reduce it by much further. And similarly, in the intermediate risk TWIST group, when you use ultrasound, it actually leads to no missed torsions at all. And overall, the data is from the US, but there was very little, so 30 to 60-minute delay in utilizing ultrasound in the pathway. And I think most of us can agree that in a UK hospital, there usually is at least 30 to 60 minutes before the patient arrives in theatre. And there is a commonly held belief that I believe is not correct. And that is that if the test is not absolutely perfect, then I'm not going to use it because of the risk of missing one torsion. And this is just incorrect in my opinion, because that's not how clinical practice is. Our clinical decision making is never just based on one parameter. We use clinical acumen, but we also use imaging such as ultrasound. We use nomograms, and we actually combine all of these various parameters to make a informed decision, and also make an informed decision with the patient on what we should do next. And again, I use the word informed decision because ultimately it is a decision with the patient. The patient needs to understand some of the uncertainties around the potential diagnosis. And I've taken a paragraph from one of the Montgomery conclusions, and although it doesn't directly apply to this scenario, it is quite an apt conclusion. And it reads, "It is not possible to consider a particular medical procedure in isolation from its alternatives. Most decisions about medical care are not simply yes or no answers. There are choices to be made, arguments for and against each of the options to be considered, and sufficient information must be given so that this can be done." And I think that's the key. It's about utilizing all of this information that we have and relaying it to the patient and subsequently making a decision together about their best care. And the key with all of this is going to be how we now utilize this in clinical practice, and Kieran's going to explain more. Thank you.
Okay, thank you very much for that, Tamer. Really interesting talk. My name's Kieran Clement, and I am one of the other Burst Core committee members, and I'm going to talk about one of our new projects called Detox, which has been in the works for a couple of years now. So it's 1 o'clock in the morning, you receive a phone call from A&E. You've got a 17-year-old boy with slow onset worsening left testicular pain for the last 6 hours or so. He's got a bit of mild suprapubic pain, he's a bit nauseous, but no symptoms of a UTI, no history of trauma, but he is sexually active. Urine dip shows leukocytes only, observations are normal, and he's apyrexial. You examine him and he's got tender, mildly swollen left testicle, but it's normal lie, no blue dot sign. Abdomen's a bit tender suprapubically, but nothing else, and he actually looks quite comfortable. So I suppose the question is, what do you do? And I would bet the vast majority of people in this situation would explore. Some people might just admit him and do an ultrasound in the morning. Some might try and persuade the radiologist to do an ultrasound overnight, probably unlikely. Some might just give antibiotics because he's got leukocytes in his urine and a bit of suprapubic pain. Some might discharge, but I would bet the vast majority in that age would probably explore. So why is that wrong, or why is that difficult? So the negative exploration rate, as Tamer's already said, is 20 to 50%. So 20% in Morton et al. 2018, 50% Maluku, 46% in Nasson. That's quite high for what is essentially a diagnostic test. So is this rate of negative torsion in exploration acceptable? So we asked our PPI representative last year, and she said, in this day and age where diagnostic imagery has come on leaps and bounds, it isn't really acceptable to do an exploratory operation in order to get that diagnosis. And then when we first presented this, Simon Morton presented it in 2018 at our burst session. One of the audience members said, we sit here in 2018 and the diagnostic test for testicular torsion is an operative procedure with a 20% positive predictive value. That can't be right, can it? Quite a contentious viewpoint, I guess, for the vast majority of urologists. So what are the alternatives? So as Tamer said, you could try and get an ultrasound, but it's not routinely available out of hours, and it could delay the time of theatre. The twist score is good if they have a score of 5, 6, or 7, but what about in those patients with a twist score of 3 and 4? Those patients, and you're not really sure whether you should be exploring or not, and that's where the difficulty comes in. So that takes us to Detox. So it's detection of torsion by registrars and training, and our overarching aim of this project is going to be determine whether POCUS, point of care ultrasound, and the twist score can be incorporated in routine clinical practice in the UK in order to better select patients for scrotal exploration. How are we going to do it? So 3 phases we've planned. So the first is incorporate POCUS into the clinical pathway. The second is to determine the accuracy of that in this setting. And then thirdly, to assess whether POCUS could reduce the negative rate of negative exploration whilst maintaining a low to zero rate of mistorsion. Arguably, the first bit's quite difficult, and the second and third bit are actually a wee bit easier, so I'll start with them. So phases 2 and 3. So phase 2 is essentially a diagnostic accuracy study. Patients come into A&E with acute scrotal pain. You assess them as you would normally, and you make the decision as to whether you're going to take them to theatre or not. Once that decision's been made, we then will ask registrars to do a scrotal ultrasound after appropriate training. And from that, we can get the sensitivity, specificity, positive and negative predictive value. For the patients that aren't being explored, we're going to follow them up at probably about 90 days to determine whether they've come back to A&E, GP's made a referral, whether they've had another ultrasound. Secondary outcomes will be adverse events, rate of testicular atrophy, rate of mistorsion, or rate of negative exploration. And then the dream for BURST, we aim to do an interventional study one day, is to, if phase 2 works well, we could then move on to an RCT on POCUS. The difficult part comes in phase 1. How do we actually train urologists to do ultrasound? How do we incorporate that into the clinical pathway? There's been a few studies on that previously. So the first one in Canada carried out a joint genitourinary POCUS teaching program for the emergency physicians and the urology residents, and then assessed them. In another centre in America, they have intra-departmental certification that rates residents and attendings into different user levels. And then thirdly, in Canada, another one they've done is a Delphi study where they looked at 24 residents in urology, trained them how to do POCUS, and then assessed them. That's not actually made it to clinical practice or a published study as of yet. The phase 1 outcomes would be feasibility. How easy and successful is it to train urologists in ultrasound? How easy is it to access ultrasound when you need it at 1 o'clock in the morning? Images of adequate quality to make a diagnosis, time taken to perform the ultrasound, does it delay patients in getting to theatre? And this is essentially our feasibility study. The overall Detox Objectives is to investigate the diagnostic accuracy of Doppler scrotal ultrasound carried out with surgical registrars in patients undergoing emergency scrotal exploration. Secondary objectives would be to determine current clinical practice regarding investigation and management of patients presenting with acute scrotal pain. That would give us new data for the UK, and they can also further elucidate the previous studies and the incidence of negative exploration. We'll be able to assess the predictive value of clinical features in patients presenting with acute scrotal pain to identify torsion. And then potentially, if ultrasound works, we'll be able to develop a composite score utilising clinical and radiological features to predict the likelihood of testicular torsion using ultrasound performed by surgical registrars. And if it's proven successful, it may well be that in the future ultrasound training is incorporated into specialty training curricula for surgical trainees involved in the assessment of acute testicular pain. And that might seem a bit of a blue sky dream, but the gynecologists do it. They have training as part of their the curricula. Why can't we? So join the POCUS revolution. This project's just still in the feasibility phase. I'd be happy for any thoughts emailed to me or through Twitter, and if anyone's keen to be involved, please get in touch. Thank you.
Thank you for asking me to speak in the BURST FRCS Urol micro teaching session with a title that's hardly micro, it's rather macro: evidence for the use of stents post-ureteroscopy, different stent designs and materials, and how to manage stent symptoms. So what I've done is I've made it into 5 Ds to make it easier. Talking about stents and minimizing the symptoms, we can talk about design, deployment, drugs, the dwell time, and most importantly, don't do it routinely. Stents come in all different sizes and shapes: JJs, spiral, tailed stents, dual durometer, multi-length stents, coated stents, drug-eluting stents. The reason that there are so many types is that there is no one design that avoids stent symptoms completely. And here's a study that shows it. So this is a Jamie Lingerman study with Glenn Preminger and some of the big names of endourology, a 4-arm multi-center study with over 200 patients assessed rigorously by the USSQ, both at baseline, at day 4 and day 30. And whether the patient had a short loop, a long loop, a Percufix Plus, or the Polaris stent, the outcomes were all the same. But the thing that's useful, and that's why it's in red, the pain worsened from baseline to day 4. This is really valuable clinical information for the patient. It's going to get worse before it gets better, although the pain medication use peaked on day 1 and then gradually improved as they got used to it. But perhaps something for the future is the use of silicone. This is some of Ollie Wiseman's work using silicone-coated stents, multi-center, single-blind, prospective randomized trial, good numbers, 140 patients, stents removed at just under 3 weeks, and the majority of the patients completed the trial. And what you can see, the Coloplast silicone stent versus a Boston Percuflex stent, the pain scores were a bit less, and the symptom scores a bit less favoring silicone. But of course, you can equally interpret this that if you're putting in a stent, the patient is going to get some symptoms. And that's why when we get to the end, not doing it at all needs important consideration. Deployment, where the stent is positioned. So care and attention to detail are the endourologist buzzwords. This is a study of 86 patients, including Frank Keeley, stents removed at 4 weeks post-op and again assessed by the USSQ, firstly after a week, then after 4 weeks, and then another 4 weeks after the stent was removed. And what this table shows, the key point, is the location of the stent loop is really important, more important than any other of the features in multivariate analysis. So if the stent loop is not in the right place, symptoms are worse, whole body pain is worse, general health feels worse, and everything is worse. So get it right first time. And if the distal loop of the stent crosses the midline, that's an adverse predictor. And one of my phrases, the best time to take the patient back to theatre is when they're already on the operating table. So if the stent doesn't look right, then you can fix it right there and then, and I'm sure your patients will be grateful for it. The next D is drugs, with the main two being alpha blockers and anticholinergics. Alpha blockers improve pain and general health with stents in. They improve quality of life and the urinary and voiding symptoms, but don't make a great deal of difference for storage symptoms. And as you would expect, don't really improve sexual function or work performance. And because of the lack of effect on storage symptoms comes the anticholinergic story. Those also improve IPSS score, quality of life and pain score. In combination with an alpha blocker gives a superior result to either one drug alone. As always, the need for further studies in the field. So the next D is dwell time. All stents, as we've said, cause symptoms. So the patient overall will have less of them if the stent is in for a shorter amount of time. And if the stent's left on a string, then the stent gets removed sooner. A median of 10 days without a string, 6 days if the patient has got a string. It doesn't worsen stent symptoms. It doesn't increase post-operative morbidity. Of course, it reduces the cost. There's much less chance of a forgotten stent, but one size doesn't fit all. And in this particular study, which was the first randomized trial of its kind, as you can see, about 1 in 8 patients, the strings were left on and the stent got removed rather sooner. So a word that we have, you should never put a stent on a string in if you would be upset by a call from recovery saying that there was this stray suture that was left sticking out of the patient. So they tidied it up and with it came the stent. Is that a problem? If that would make you upset, then a stent on a string isn't appropriate. And some of the conditions that would make you think twice, solitary kidney, congenital anomalies that are just going to be more difficult, pregnancy, obviously, bilateral ureteroscopy, all common sense. And from one comes many, and a systematic review confirms that stents on strings are reasonable, no difference in pain and symptoms. About 1 in 10 by now, perhaps we've got better at doing it, gets dislodged early, confirmed that the dwell time is shorter. And this is also quite useful for COVID times. The majority of patients can just remove the stent at home. We do this, one of our nurses gives the patient a ring and talks them through it, and it's worked perfectly well during the coronavirus time. And then finally, the most important D is don't do it. Don't put one in at all. This is an important paper, very well quoted and something that's useful to know for the exam. Harishi Joshi, when he was in Bristol, that about 80% of patients who've got a stent will have some sort of bother. pain, urinary symptoms, reduced work, and sexual dysfunction. Bringing us to the NICE guidelines of 2019 with the bold statement, do not routinely offer post-treatment stenting to adults who've had ureteroscopy for stones in the ureter of less than 20 millimeters. So you'll all be familiar with the main document, but this is the sub-document, 110 pages, I think this one is, and as you can see on the right-hand side, 61 or 81 studies analysed for this, of which 17 were appropriate to interrogate in detail. And in particular, to answer the question, what is the rationale for a post-operative JJ stent? To relieve obstruction and uncontrollable pain in an emergency, and in the elective post-op situation, for the risk of obstruction, and then very much in inverted commas, to enhance fragment passage, because actually we know from shockwave lithotripsy that that isn't true. So these were some of the outcomes that the NICE team looked at. These are the important things: stone-free rate, recurrence risk, length of stay, major and minor adverse events. And as you can see at the bottom, kidney function, quality of life, and failure to perform the procedure are important, but actually there was no sufficiently good evidence for those things for them to review. And these are the data. Ureteric stones of less than 10 millimeters, no benefit of ureteroscopy plus a stent, and indeed because of the stent symptoms, a considerable benefit of just performing the ureteroscopy alone and unstented. And the same for larger stones as well. Benefit for absence of stent symptoms without putting in a stent. So that was their conclusion. And yet despite that, we know from our own studies that about 70% of patients still receive a stent after ureteroscopy, with the rationale of avoiding problems that are unlikely to occur or to improve things that we know just don't happen. But of course, it's all about balance. All of these studies included the high-risk patients or who'd had a complicated procedure because they were randomized at the end of it rather than at the beginning. So clearly, if you have a condition of any of the things in red, then you're going to put in a stent. So this was their conclusion. Stents should be considered when further treatment is needed. And for me personally, that's you're doing a second phase procedure. That's the strongest. If you're concerned about infection, obstruction, solitary kidney, or the patient has had an intraoperative complication, and mirrors the EAU guidelines of patients who are at increased risk of complications. It's just worth mentioning their bottom line, the doubtful cases to avoid a stressful emergency. I think we've shown that much of the stress with a stent is taken by the patient rather than the surgeon. So I've covered design, deployment, keep the stent on its own side of the bladder. We've talked about drugs as alpha blockers and anticholinergics. Dwell time, shorter is better than longer. And most importantly, and supported by the NICE guidelines, don't do it routinely, which gives us a sixth D. It's a decision, it's a balance, and stents routinely should not be done, but stents for cause make good sense. So for those of you who are sitting the exam, I hope that that's useful. The cat is you. The line of Alsatians are the examiners. So brimful of confidence, any question relating to stents or post-operative drainage, you can walk on by with your head held up high and hope that the result will be favourable. Very best of luck.
Hi, I'm Nikita. I'm the co-vice chair-elect of BURST. Today I'm going to talk on our stent study. Why do we stent our patients after uncomplicated ureteroscopies? Often while I have a discussion with my patients, I tell them that this is a necessary evil. Evil because they hurt. 6 out of 10 patients don't like them. It's necessary because a lot of people believe that if you don't put one in, patients are going to come back as an emergency and they may require a stent later. But is this really true? Is this evidence-based practice, or are we practicing defensive medicine? What do we know about the evidence? NICE and EAU guidelines have said clinicians should not leave stents after uncomplicated ureteroscopies. NICE has defined this anything less than 2 centimeters in stone size, whereas EAU has specific criteria, which I'll come to later. Ureteric drainage, however, internationally is quite variable, and there are a few audits to suggest there's a high tendency of temporary ureteric stenting even after uncomplicated ureteroscopy. There has been a Cochrane review on ureteral stenting after uncomplicated ureteroscopy. This said that the desirable and undesirable effects of stents were small in absolute terms. There's a lot of limitation and imprecision in all included studies. There is hence a need to conduct higher quality, sufficiently powered trials to answer this important question that clearly affects clinical decision-making. So if you look at the literature, in 2007 and 11, systematic reviews that only included uncomplicated ureteroscopies as per EAU guidelines show that there's no difference between stenting and the unstented groups in terms of LUTs, analgesia, stricture rate, etc. After this, there were two systematic reviews that were conducted 2016 and 17 that included patients both with uncomplicated and complicated ureteroscopy, one of which also included ESWL. These systematic reviews showed there's a higher rate of unplanned medical visits in the unstented patients, but this is not the same. How long should you stent these patients? There's very limited evidence. There's a single center RCT that says 3 days is not quite enough and you need it for 7 days, and a retrospective cohort study that's quite old now that says that longer than 2 weeks is significantly related with adverse events compared to less than that. All of these trials, however, if you notice, are missing a key factor, and that is patient-reported outcome measures. In a thing that really affects every single aspect of a patient's life, we're not really asking the patients what do they want. And there are different tools such as the CUSP tool or the Wisconsin tool that will help us to determine what the patients want with respect to stenting versus not stenting. Our aim was to assess the uncertainties about the feasibility of conducting a randomized control trial, assessing whether not stenting after uncomplicated ureteroscopy is superior to routine ureteric drainage, for example, a stent or equivalent. We also wanted to understand current views and practice with regards to ureteral stenting after uncomplicated ureteroscopy. We used a mixed methods model with an international online survey-based feasibility study and used a number of platforms to disseminate our survey. We're very thankful to all the societies that helped us do this. We use REDCap as our platform, and we defined an index patient as someone who has had a definitive uncomplicated ureterorhinoscopy, and fragmentation with laser for ureteric or renal stones. We defined definitive as a final ureteroscopy for stone disease when the patient is not waiting for any further treatment, and uncomplicated was defined as per the EAU guidelines. Following the procedure, the clinician has an option to either place a stent or equivalent or not decide to place one. We're very thankful to all our respondents, over 400 of them, out of which 300 completed all questions. Nearly 70% were consultants. The first question was the volume of ureterorhinoscopies that were performed by our respondents. As you can see in this graph, over 78% of our respondents performed at least more than 5 ureteroscopies a month. So a lot of them were quite high volume surgeons. But then when you look at this graph and you look at the frequency of stenting, nearly half of them stented almost all the time. That's quite significant. We then asked them about their ureteric drainage in practice compared to their personal preference of ureteric drainage if they had a stone and required an uncomplicated ureteroscopy. This from 92% in patients that they perform dropped to 70% if they were themselves patients or a family member was a patient. So what is the reason for this discrepancy and difference in practice? We asked them about their indwelling stent duration, and this was in a majority only less than 2 weeks as per the clinicians. However, there are a few, about 6% who had stents for over 4 weeks, 6% for 3 to 4 weeks. In patients who do not require a stent, this is quite significant. The criteria for why would you typically leave a stent were quite typical, as you would expect, to reduce the risk of obstruction, to aid the passage of small fragments, to reduce admissions, etc. This is not something that's entirely new to us. However, we specifically asked them what criteria they use to decide this, and we found that a lot of the things that the clinicians used in clinical practice was not a part of the guidelines when it was defining uncomplicated ureteroscopies. We hence use these criteria to form specific scenarios. And if you can focus on the blue, which is the unstented group, the orange, which is ureteric catheter overnight, the gray is a stent on a string, and the yellow is someone who's had a stent. And if you go from top to bottom, you will see in the top scenarios, such as the pre-stented ureter, rigid ureteroscopy on its own, operation time 45 minutes, the number of clinicians who did not leave a stent was much higher. Whereas if you come down, the number of clinicians when they left a stent for things like op time of over 90 minutes, access sheath in an unstented ureter, impacted stone, etc. was much higher. Whereas the ureteric catheter group and the stent on a string group tend to stay more or less constant at about a third and less than 10%. We then finally asked them about their equipoise. So in a multi-center randomized controlled trial that is looking at outcomes, patient-reported outcomes, and 30-day readmission rate after different options for ureteric drainage, post-definitive uncomplicated ureteroscopy, we found that over 81% of our respondents were happy to randomize patients. However, the number who were more comfortable randomizing after in the stented arm was higher than the number that were happy to stent in the unstented arm. So people were more comfortable with randomizing to the stented arm compared to the unstented arm. So in conclusion, we know that stents have severe morbidity, cost, and effect on quality of life. This may be a short time for us, but it is a significant time in the patient's life, and it has a big effect in all different aspects of the patient's life. The current evidence on use has clearly limitations. There are no RCTs looking at patient-reported outcome measures. Current practice, even in our survey, still favors stenting. There are several criteria that we have now identified to stent in practice. And based on these criteria, we may need to redefine what an uncomplicated ureteroscopy is. There is equipoise to participate in an RCT. We're very happy to announce that our article has been recently published in the BJUI Compass, which is open access. So feel free to go and download it and read all the details of this survey. We'd like to thank all our respondents and all the different societies who supported us in disseminating and answering the survey. Thank you.
Hello, my name is Toby Page from the Freeman Hospital in Newcastle, and I'm going to spend about 5 minutes talking about the state of medical school urology education and changes in the COVID era. Where are we at the moment? Well, we've heard all about the LEARN study, amazing 1,000 responses in the first 48 hours, a really good picture of the state of urology teaching currently. Historically, we know that less than 10% of F1s feel they've had adequate urology training. 25% of medical students say they've had no training at all, and 30% less than 7 days. Clearly not enough, given how important urology is in all sorts of medical and surgical experiences. If we look at podcasts out there, very few urology podcasts compared to a specialty average of 8. Next generation, we know nearly 20% of medical students don't know what they want to do when they graduate. We know that nearly half have done less than 5 rectal examinations during their training. So clearly, if you're going to be a GP, surgeon, whatever, this is a low number. 48% have done less than 2 catheters in their entire training. And if we look at the number of applications to STR training and SPR training, it's gone from 18 to 1 in 2007 to 2 to 1 in 2018. Clearly less popular, although we have had an increase in the number of training numbers. What's happened during the COVID Lockdown, some medical schools have really been proactive, some have done absolutely nothing. Some good examples are surgical skill sets where medical students have been given sets of equipment to practice surgical skills at home whilst locked down. Many departments have started e-teaching for their F1s, ST trainees and consultants, and inviting medical students to this is an easy win. Harvard in America have spent an enormous amount of money developing their e-learning edX platform. Very impressive if you've got the money to do it. Royal College of Surgeons in Edinburgh have a webinar series, and perhaps the most impressive is what medical students have done for themselves with the Smile group on Facebook. An example of a surgical skill set is here, the sort of thing that medical students have been given to practice gowning. Some have made models to practice catheterization and similar skills with suturing. The Smile website is really a fantastic resource. As you can see here, nearly half of all medical students in the UK, 14,000 medical students, have registered on this website to go to these online teaching sessions. An amazing response to the COVID outbreak to have this platform that links medical students across the country. There has been an expansion in medical student numbers, so hopefully these sort of platforms will be a way to really link people together. Locally, there's been some really new exciting developments in medical education, particularly Oxford Medical Simulation using Oculus virtual reality headsets, really state-of-the-art methods of teaching. Here you can see a simulated view. The blue hands represent the medical student doing his examination and really using virtual reality in a fairly cheap format, Oculus Rift headsets being fairly affordable. Clearly, there is a lot of knowledge already out there on the internet for medical students to access. There are a number of websites that you can access for free. One I particularly like is the Teach Me Surgery website. Covers 29 urology topics, including everything in the BAUS curriculum. I'm not paid by Teach Me Surgery, I'm not involved with them, but I think it's a very nice website. Royal College of Surgeons have their own e-integrity website as well. This is the Teach Me Surgery website, a really good resource. As you can see, there are a number of different resources there, all peer reviewed, all kept up to date. And it even has a TripAdvisor-like ranking. So once you've gone through a module, you can feedback what you thought of it and rate the article. Completely free, the knowledge is there, it covers the curriculum. So we don't really need to be worrying about how we offer this type of knowledge resource, it's all there. Royal College of Surgeons of England have their own equivalent. For members of the college, clearly you have to be signed up to that. So what should BAUS be doing? Really, as a group, we probably need to be thinking about a standardized knowledge assessment that we could offer to medical schools. The knowledge base is there, but it's having a method that medical schools can assess that. And maybe BAUS should be leading on that, really suggesting to medical schools, here are some online assessments that we think are validated for you to use on all your medical students at some point during their training. Virtual clinics have been set up by a number of different organisations, including the EAU. A virtual clinic has a number of case-based scenarios that medical students and junior doctors can work through. What about live streaming? Certainly, we want to involve medical students in surgery, but getting them into theatre can be intimidating, can be difficult. And maybe we need to think a little bit more about live streaming or as live streaming of operating, and possibly going a little bit further using Google Glasses and similar on the ward round or even in clinic. Perhaps the most important thing, though, is interaction. Clearly, there are issues with live streaming about consent and control of access. We can't have everyone dialing in to watch us operating, but it has many advantages for medical students and advantages for us as teachers because it's less time consuming and would really give a very good insight into our daily practice. We've already got a network of medical student urology champions, but perhaps we need to get a little bit nearer to medical students with nearer peer learners, perhaps either early year consultants or SPRs. And really, I think the big thing we need to think about is having medical student urology champions as well as trained either consultants or SPRs Clearly, there are groups of medical students who are very dedicated to urology. The SA prize really demonstrates that, and we need to tap into them so that they can actually liaise with BAUS and their own peers in their medical schools. Talking to them, they often use small Facebook groups that they run themselves to talk about teaching or sessions, and if we can tap into that, that would be very useful. As individuals, what can we all do? Firstly, we need to acknowledge that medical students are there, and we really need to interact with them. If you see a medical student, be nice to identify yourself to them, introduce yourself, try not to be too threatening, and really offer anything. Even if you don't think you've got anything to offer, I'm sure there will be skills that medical students would really be happy to go, whether it's sitting in a clinic, whether it's going on a ward round, whether it's going to theatre, anything that really involves them about urology is a good thing. Mentorship and building up a relationship with medical students and supporting them through many years or through electives or through student selected study modules is really important. And we all have a duty really to promote urology at every opportunity, not just to convert medical students to being urologists, but also doctors in their daily practice are going to have exposure to urology, and it's important that we give them adequate education. Thank you very much.
Good afternoon, I'm Alex, a medical student at University College London and lead for the LEARN study, an evaluation of urology teaching at medical school. Urological conditions are common, and urology is also a common rotation for UK Foundation Year 1 and 2 doctors. Whilst the standards and outcomes for medical education in the UK are regulated by a public body, variability in the exposure to each specialty still exists, and this could lead to deficiencies in training doctors with the knowledge and skills to manage basic urological conditions. There are international reports on the declining exposure of urology during medical school. In 1966, John Latimer warned that the loss of urology teaching could cripple the growth of our specialty. Since then, the percentage of US medical schools requiring a urology rotation has decreased from 99% in 1956 to just 17% 10 years ago. A 2001 report highlighted that 2 UK medical schools required no exposure to urology, and a 2008 US survey found that 65% of medical school directors stated that it was possible for students to graduate from their university without a clinical rotation in urology. The paradigm shift of the undergraduate curricula towards primary care and student sector components has resulted in students receiving, on average, just 1 week of urology teaching. And this potentially contributes to only 15% of medical students having considered a career in urology, and a fourfold decline in urology specialty training competition ratios from 8:1 to 2:1 over a 10-year period. A 2014 report found that 40% of Foundation Year 1 doctors in the UK did not perform male catheterization, and 64% had not performed a female catheterization whilst in medical school. National governance bodies clearly define the urological competencies required of newly qualified doctors. For example, the BAUS undergraduate syllabus, the GMC's outcomes of graduates, and the ASIC consensus report, all stating the requirements for graduates to be competent in urological skills, such as catheterization. To ensure consistency in undergraduate education, BAUS released the undergraduate syllabus for urology in 2012, giving recommendations on common clinical areas of urology that should be covered during undergraduate training. It was published as a result of junior doctors feeling insufficiently equipped to manage basic urological conditions. Despite the existence of this national syllabus, its uptake nationally remains unknown. LEARN is a national multi-centre audit of urology teaching across British medical schools, led by the BURST Research Collaborative. The study is led and primarily run by medical students. LEARN aims to assess undergraduate teaching across UK medical schools, with the primary objective to compare current teaching against the BAUS syllabus, and with secondary objectives investigating the type and quantity of teaching, the perceived confidence in the management of urological conditions, and the proportion of students expressing an interest in urology as a future career option. Over 500 collaborators have been recruited through a targeted advertising drive. Collaborators are responsible for recruiting survey respondents to complete a REDCap survey, retrospectively assessing their urology teaching to date. At the time of recording, we have received over 5,000 survey responses from 38 out of 39 medical schools included in this study. Our top 5 recruiting medical schools are Birmingham, Nottingham, UCL, Leeds, and Imperial. 95% of survey respondents are medical students and 5% are foundation year 1 doctors. There is a good distribution of responses across all year groups amongst undergraduate and graduate medical students. Unless otherwise stated, responses from here on are based on foundation year 1 doctors, as they represent the cohort of those who have completed all years of the medical degree. Year 1 medical students are not included in this study due to the retrospective nature. When asked about the teaching topics covered during medical school, it is promising to see that students receive a wide variety of teaching topics. The most commonly taught topics include acute kidney injury, urinary tract infections, hematuria, and acute renal tract stone disease. The least commonly taught topics include erectile dysfunction, male infertility, and urinary incontinence in male patients. It is interesting to note that 3 respondents said that they received none of these teaching topics during medical school, and for each of these teaching topics, the red bar on the left highlights those who have not received teaching for this topic. When asked about male genital examination, 25% said that they had not observed one, and 35% have not performed one on the patient. When asked about digital rectal examination, only 2% said that they had not observed one, and 7% have not performed one on the patient. When asked about male catheterization, 2% have not observed one, and 5% have not performed one on the patient. When asked about female catheterization, 15% said they had not observed one, and 21% have not performed one on the patient. The difference in clinical skill experience is evident when asked about the perceived confidence in inserting a male catheter, where the mean confidence is 68, with 0 being not confident and 100 being very confident. And for a female catheter, where the mean confidence is only 55. When asked about a career in urology, 20% said that they have or are considering a career in urology, which is the same when compared to the response from all respondents. When asked about the urology teaching provided in medical schools, 47% said that they felt that this was insufficient compared to 53% when compared to all respondents. When asked about information provided regarding a career in urology and the training pathway, 72% felt that they had received not enough information compared to 82% of all respondents. Learn has a good uptake nationally. Our preliminary results based on the Foundation Year 1 cohort suggest a wide variety of topics are being taught. However, there are some who have not received teaching in common presentations. With regards to clinical skills, there are reports that Foundation Year 1 doctors have not performed male genital examination, digital rectal examination, and male and female catheterization on patients. And whilst this is significantly better than the 2014 UK study, this is still of concern, as the GMC lists male and female catheterization in their practical skills and procedures, and requires newly qualified doctors to have performed on real patients during medical school. With regards to career and exposure, only 20% of Foundation Year 1 doctors have or are considering a career in urology, and surprisingly, this is higher than previous reports of only 15%. With high levels of perceived insufficient teaching and insufficient career and training information, this highlights areas that we can improve on to stimulate interest in urology. Our early results are promising. Whilst we have only covered a small portion of our data so far, and have only looked at the Foundation Year 1 doctor cohort, our full analysis will provide an insight into the urology teaching provided for each year group and overall during medical school. With successful participation nationally at over 5,000 responses, Learn will be the most representative and thorough evaluation of UK undergraduate urology teaching. The results of this audit will enable us to make recommendations on how to improve or maintain standards, provide evidence to support changes to the medical school curriculum, and enable a re-evaluation of the current national undergraduate BHATT syllabus. Thank you for listening, and I would like to thank my colleagues who are part of the Learn study team for making this all possible. Thank you.
Hello, my name is Ben Ayers. I'm a consultant urologist and honorary senior lecturer at St George's University Hospital NHS Trust. I'd like to thank the organisers for asking me to talk today, and I'm talking to you about some of the evidence behind the diagnosis of urothelial cancer. These are my disclosures. One of the first and key papers on diagnosis of urothelial cancer came out of the Hematuria Clinic at Newcastle. This was published in 2000 and assessed patients coming through their Hematuria Clinic between 1994 and 1997. Their protocol was to do a plain KUB X-ray, an IVP, ultrasound scan, flexible cystoscopy, urine cytology, bloods, and urinalysis. They found that 12% of the patients referred to them had bladder cancer, 13% urinary tract infection, and 2% stones. They also found a small number had renal and upper tract transitional cell carcinoma. Only 4 presented of these renal or upper tract cancers presented with microscopic hematuria. And they also reported that if only an ultrasound scan or an IVP had been used, then 4 of them would have been missed. So they did argue that using both an ultrasound scan and IVP jointly was important. They found that only 5% of patients with microscopic or non-visible hematuria had cancer, but they did find bladder cancer in young people. They did find it in 7 people that were younger than 40. Another study, this time from Plymouth, on 4,020 patients coming through a hematuria clinic, showed that cancer again was found in 12.1%, more in patients with visible hematuria compared to those with non-visible hematuria. And again, the non-visible hematuria rate was close to 5% at 4.8%. Again, their protocol was a bit different in that they used an ultrasound scan and flexible cystoscopy and only added in an IVU if there were abnormal findings at ultrasound scan or persistent hematuria. They diagnosed 70 upper tract tumours after an abnormal ultrasound scan and found that 3 cases of upper tract TCC occurred on an IVU after a normal ultrasound scan. And therefore, again, without both ultrasound and IVU, some tumours would have been missed. Interestingly, they also looked at the first year cohort and reviewed their notes 4 years later to see if any tumours had been subsequently diagnosed, i.e. tumours missed at the original hematuria clinic. And they found that 10 patients potentially had missed tumours. The probability of missing a tumour overall was 1.7% and was particularly low if they had non-visible hematuria at less than 1%. It was higher in male patients, those over 60, and those with visible hematuria. More recently, the Identify study has looked at hematuria and diagnosis of bladder and other cancers through the hematuria pathway. And I know that they're talking about this study after me, so I will not talk any more on this at this stage. We've talked about ultrasound and IVPs, but nowadays most of us, I would suggest, use a CT urogram as part of our investigation of visible hematuria. This study from Oxford looked at the role of CT urogram along with cytology and flexible cystoscopy in patients with visible hematuria. In total, 20% of the patients had bladder cancer. And as you can see from the right side of the slide, sensitivity and specificity for CT urogram, flexible cystoscopy were high, and if combined, even higher. And what they did was when the CT urogram was positive, they went straight to rigid cystoscopy and TURBT, and this led to a 17% reduction in use of flexible cystoscopy. However, what they did report was that urine cytology, whilst being highly specific, was not very sensitive. Another paper here looking at the use of CT urogram in hematuria clinic patients found that there were false negatives if an ultrasound scan was performed, and 5 patients were missed with a renal mass and 2 patients were missed with an upper tract TCC. However, one part of this study that would be different from a lot of our practice is that the ultrasound scan was performed by urologists and not by dedicated radiologists. But they concluded that visible hematuria should have a CT urogram and non-visible hematuria should have an ultrasound scan, because the chance of missing a cancer was higher in the visible hematuria cohort. NICE guidelines on bladder cancer diagnosis and management suggests that when assessing a patient for bladder cancer, we should not only perform white light cystoscopy and TURBT, but also add in optical enhancement, either in the form of photodynamic diagnosis or narrowband imaging, or add in cytology or a urinary biomarker test. And this is to help us pick up high-risk non-muscle invasive bladder cancer, in particular carcinoma in situ. This is a study using photodynamic diagnosis. And as you can see, the percentage of carcinoma in situ picked up by PDD was 97% compared to 58% with white light. There were also higher detection rates of papillary tumors as well. But it's not just PDD that enhances what we see in the bladder. Narrowband imaging is also available. And as you can see from this study from Denmark, narrowband imaging was equally effective at picking up carcinoma in situ with a sensitivity of 95.7% compared to 95.7% for PDD and 65.2% for white light. What about urine cytology in diagnosing urothelial cancer? We've seen from the Oxford group that it was highly specific, but not very sensitive. And another study here on 567 patients going through the DETECT-1 study, again, showed high rates of specificity, but lower rates of sensitivity at 43.5%. Specificity rates, as I said, were high at 95.7%. And therefore, this leads to false negatives and false positives. With the false negatives, they missed 21 bladder cancers, 12 of which were high grade and 4 which were muscle invasive, and they missed 5 upper tract TCCs. The false positives, 12 of them had further invasive tests that one could argue were not necessary, but important clearly to investigate the positive cytology, and none of them developed any cancer during follow-up, which is why they've been labeled false positives. Urinary markers have been on the scene for quite a number of years and keep promising to improve diagnostics, but are not quite there yet. However, with falling prices of genetics and genetic tests and proteomics, I think they're going to be more part of our future. One really interesting one is Euromark, being developed at University College Hospital, and this looks at 150 loci biomarker panel using DNA methylation and comparing primary bladder cancer urine to non-bladder cancer urine. In initial studies, it had a 98% sensitivity and 97% specificity, so significantly high. Normally, urinary markers have higher sensitivity than cytology, but lower specificity, but not in this case. And they're currently at DETECT-1 and 2 studies are underway to test this in the real world setting. There are other options to assessing urine for bladder cancer. You can look at volatile organic compounds, and there's proteomics as well. And as I said, with the falling price, hopefully these will become more and more widespread and used in our practice. So my take-home messages in diagnosing urothelial cancer is that if you use ultrasound scan alone in a hematuria clinic setting, you will miss some upper tract tumors. Urine cytology has low sensitivity but high specificity, and therefore is not cannot replace cystoscopy in terms of a diagnostic tool for bladder cancer. Optical enhancement improves tumor detection, especially carcinoma in situ. Urinary markers have been promising a lot for quite some time now, but hopefully with a reduction in technology costs they may become a reality soon. And if a patient has non-visible hematuria and negative investigations, you're unlikely to have missed a cancer. Thank you for your attention, and I'll now open the floor to any questions.
Hi, my name is Sinan Kadori. Thank you for listening to one of the last talks of the conference. I'm going to talk to you about some of the key findings from the Identify study and whether this should change the way we diagnose cancer in patients with hematuria. So I'm just going to go through a summary of the study and its findings, and the main results, which are the prevalence data. Have a look at the diagnostic predictive model from the risk factor analysis, and some of the diagnostic test evaluation, especially with in the context of COVID, and touch a bit upon what comes next after that. So, as many of you will know, Identify was a study about patients referred to secondary care with suspected urinary tract cancer. It was a prospective observational study in over 11,000 patients, 26 countries, 110 hospitals. And what we found was more men were referred than women, and more people with visible hematuria. The median age was 66, and men tended to be referred more with visible hematuria, women with non-visible hematuria. As expected, the highest prevalence rate was in bladder cancer, and that was about 17.9%, with the other cancers, upper tract urothelial, renal cell carcinoma, and prostate, being approximately 1%. And if we look at the numbers and the breakdown by the type of hematuria, you can see that the majority of cancers are in the visible hematuria group. For example, bladder cancer in the visible hematuria group is 22.4%, and in the non-visible hematuria group, 5.23%. The no hematuria group are patients that were referred with an already confirmed suspicious lesion on imaging, or those with suspicious symptoms. So they're a different group altogether. And for further analysis in this presentation, we haven't included them. So going forward, we decided to look at risk factors and do a risk factor analysis, and started off with a mixed effect multivariable logistic regression. And we use center and country as random effects, and the factors that we are interested in as fixed effects. So we did a backwards stepwise selection of variables. So you fit the full model with all the variables, and then remove one at a time until all the variables are significant. And we did that for bladder cancer, upper tract, and renal cell carcinoma. So if we look at the bladder cancer model, here you can see a table with the variables on the left and the odds ratio. And you can see these factors that cause an increased risk in bladder cancer. So as expected, visible hematuria is the strongest predictor with an odds ratio of 4, but also smoking history, family history of urothelial cancer, and age. There was a slight increased odds of male sex associated with bladder cancer. Also in the model, we looked at other factors that showed there was a decreased risk of bladder cancer. So whether patients had a previous hematuria investigation, surprisingly low urinary tract symptoms, and that was for voiding and storage LUTs as well as mixed. If they had a UTI history associated with that presentation, any catheter use, so indwelling catheter, suprapubic or intermittent self-catheterization, a history of pelvic radiotherapy, and whether they were on anticoagulation. And if we look at the performance of this model, you can see that it has a good C statistic, a good area under the curve, and when you internally validate that with bootstrapping, you find that it doesn't have much optimism, which is good. Similarly, we did the same for upper tract urothelial cancer, and the same expected predictors came out. So hematuria, age, male, and smoking. But interestingly, flank pain was also a predictor. Also, UTI history showed a decreased risk. And in renal cancer, flank pain also came out as a predictor. So moving on, we also decided to look at some diagnostic accuracy of ultrasound and CT. And in the context of COVID, we wanted to do a simple algorithm that uses what we have already. And guidelines use age and type of hematuria. So we decided to keep it to those variables and see if we can develop an evidence-based model to improve diagnostic accuracy. All patients get a flexible cystoscopy and an imaging test. So crucially in this model, we said, why don't we use the imaging to triage patients first? So what you can do is look at the best positive predictive value and triage those patients straight to a 2RBT, and different thresholds of the negative predictive value to triage them either to a non-urgent flexible cystoscopy or to discharge them altogether. And you get this big complex table of the type of hematuria, the different age, and the type of imaging modality used, and all the different diagnostic accuracies. So we picked the best ones and came up with this model. So here is an example where you have a patient with visible hematuria, you stratify them by age, and then they have an imaging test, either an ultrasound or a CT, depending on their risk. And if it's positive, you can decide if that's a good enough positive predictive value to take them straight to theatre. And if it's negative, you can have different thresholds for discharging them or going for an urgent or routine flexible cystoscopy. So in this model, if you replace the middle age category with a CT, you get a slightly lower missed cancer rate, which is less than 3%. And you can decide, for example, to take these for patients for a routine flexible cystoscopy. And you can do the same with non-visible hematuria. And actually, if you compare these models to what the other international associations have recommended, especially during COVID, you can see that our evidence-based models have a lower proportion of missed cancers. So what's next after this? Well, really, it's to combine what I've presented to you, so the risk factor analysis with the diagnostic test evaluation, to form a diagnostic pathway for referrals. So a pathway where patients are risk stratified into low, medium, and high risk, and then they undergo a diagnostic test depending on that. And after that, it would be a case of potentially seeking to externally validate that model to make sure it's generalizable and it's of use in maybe primary care and secondary care. So in conclusion, we've reported the contemporary prevalence data of urinary tract cancer in patients with hematuria. We've explored some old and new risk factors to build a diagnostic predictive model. And this can already be used to advise international associations on referral guidance. But really, we want to combine all our data to try and build a new algorithm and a new diagnostic pathway that's efficient and saves on unnecessary investigation. Thank you so much for listening, and to all the collaborators that contributed to the identified data.
So I'd like to thank all of the speakers for their excellent talks today. We hope as an audience you have enjoyed the talks on the evidence basis behind common urological practice which influences all urologists around the world. And also for those sitting the FRCS examination, you've hopefully had a bit of a revision session. And most importantly, we hope you'll get involved in our projects, which you can see are over a diverse range of areas. And if you have any questions or would like to get involved, just drop us an email and join our mailing list. Thank you.